I'm Dr. Bonnet. I'm particularly happy to welcome you on behalf of AIPES, the Nuclear Medicine Industry Association, for this AIPES Symposium entitled Nuclear Medicine in Cancer Management, Improving Efficacy and Reducing Costs. 35 years ago, I took a summer internship in my second years of my medical school in a biophysics lab, because at that time nuclear medicine did not exist. And I remember that what I was doing at the time, the techniques that we had, the equipment that we had, and I can measure now, the fantastic development of this field in terms of equipment, tracers, markers. And nobody could have told me at that time, and I would have not believed them. You know what? In 35 years from now, you will be introducing a symposium of this kind. And I like that. Actually, I think that today the nuclear medicine industry can have two strong feelings. One is pride. The pride to be able to set up this collaboration that exists. It's a unique one between the practitioners and the people bringing to them equipment and product to enable them to make what they do every day. And without this collaboration, actually, it couldn't have been possible to go through different turbulent time that we had, some years ago when there was this famous Molly crisis, and all the actors together, stand up and decided what we want to do in order to secure reliable supply for all the key isotopes that we need to have in the future. The second feeling is excitement, because I believe that it's just a start. And we'll see that today. We're just at the entry of a new era with new tracers, new things that we can do. Combining new equipment, new techniques, new procedures, in order to address all the new medical needs that we are facing, that are growing in numbers and are changing in definition.
It's a great pleasure today to welcome you to this scientific symposium on PET, on efficacy and cancer care. It was our great pleasure and honor, I would say, that we were capable of assembling here 4 eminent researchers and scientists in the field of nuclear medicine and medical oncology. It is now my pleasure to present the first speaker. Marlene Fischer is Associate Professor of Research in the Department of Clinical Medicine, Faculty of Health at the Copenhagen University. Dr. Fischer is a well-known researcher in the field of functional imaging and oncology. Her main interest is functional imaging application in cancer treatment. She conducted, analyzed, and presented the world's first randomized clinical trial on PET-CT in non-small cell lung cancer staging that demonstrated the power of PET-CT in reducing futile thoracotomies without affecting overall survival and cost. I'm pleased to invite Professor Fischer to talk about PET-CT as cost saver in oncology, dream or reality?
Good morning, ladies and gentlemen. It's a pleasure to be able to be here and discuss with such a broad audience of both decision makers, patients, and colleagues the use of PET-CT in oncology in a broader perspective. First, I'd like to set the scene. When a patient is diagnosed with cancer, it has been compared to entering a completely different world, or perhaps like a labyrinth. The patient being at a loss whether to turn right or left, totally dependent on her or his doctor to guide them through. The doctors in turn are dependent on not only their specific knowledge about the disease in question, but also on detailed knowledge of the specific patient, the histology, the stage of the disease, and whether or not the patient is going to respond to the planned therapy. This is where imaging, especially PET-CT, has proven to be a very valuable signpost. Now, what is so special about PET? Well, first of all, you can non-invasively obtain information about the functional characteristics of the tissue. And depending on the clinical question, you can tailor your PET scan by choosing different isotopes or different traces. As we will see later on today, PET is not only FDG. Furthermore, you can combine your PET images with CT and recently MR to obtain anatomical correlates and multiparametric imaging. This is a young woman, 30-year-old, who presents with enlarged lymph nodes on the right side of her neck. A PET-CT is performed, showing that there is a physiological high uptake in brain and bladder, but also a pathologically high FDG uptake corresponding to lymph nodes on the right side of her neck and in the mediastinum. A biopsy was performed, finding that she had diffuse large cell B-cell lymphoma, and chemotherapy was initiated. She came back after 4 cycles of chemotherapy for her interim PET-CT in October. This was to find out whether or not the chemotherapy was working as planned. And we can see that the FDG uptake in the lymph nodes in the neck and in the mediastinum had been reduced, so the chemotherapy is working. However, the uptake in the mediastinum is still slightly increased, thus chemotherapy will not be enough and this patient will need radiotherapy as well. And if you look closely on the pictures, you will see that there's also something more to be found here. In the upper part of her right thyroid lobe, there is a small, highly FDG-avid foci. Now, is this lymphoma? Well, probably not, because if it was, it would not be that FDG-avid after chemotherapy. Is it an adenoma? It could be. It's a frequent finding on PET-CT. A thyroid scintigraphy was performed, and it revealed a cold nodule, which was surgically removed. And we found out that the patient also had a medullary adenocarcinoma, thus a second cancer. Finally, the patient came back in May for the last PET-CT, displaying complete metabolic and structural response, both at the neck and in the mediastinum. There's no pathological uptake left in the tissue that you can still see at the mediastinum, and the patient is, for now, cured. So this was to illustrate that we can and we should use PET-CT for diagnosing, staging, radiotherapy planning, therapy evaluation, and follow-up of cancer patients. A group in the US compared the cost of total cancer care in some major groups of oncology patients with the cost of imaging alone. And they found that the rise in imaging outpaced the rise in total cancer care cost, again by a factor 2 to 4. So while the annual cost of cancer care rised with 2 to 4%, it rised with 5 to 9% a year in the imaging part. And this rise was mainly driven by costs associated with PET in the use of lung cancer patients and lymphoma patients. So this kind of set the scene for us to look into not only the diagnostic accuracy of PET, but also the societal efficacy. This moves on to the less esteemed but more popular cost effectiveness analysis, the CEA. Here you compare the effectiveness, which could be accuracy, survival, number of futile thoracotomies, etc., and cost between alternative interventions. It is the most frequently applied method in health, and you can base it either on a clinical trial or on a modeling approach. Finally, the ugly one, which is rarely used in health science, is the cost-benefit analysis. In cost-benefit analysis, you assign a monetary value to the effect. For example, what is the value of a life year saved? What is the value of a correct diagnosis? This enables you to compare the ratio between the value of the benefit over the value of the cost. And you can compare non-related interventions. For example, which is better for society, a new scanner or a new bicycle road, or more relevant perhaps, a new expensive drugs, or more nurses. Now I'll move on to some clinical examples. I'll start with the first example is from staging of lung cancer. This is one of the best documented indications for PET-CT, and several cost-utility and cost-effectiveness analyses have been performed. There are 2 analyses. The first one is a Dutch one, and the other one is Danish, performed in our group. They both compare PET and PET-CT with standard imaging for staging of lung cancer in a randomized setting. The Dutch group did find a cost saving of 6,000 euros, where we did find an increase in cost in the PET-CT arm of almost 20,000 euros. If you look into the numbers, we were a bit surprised by that, I must admit. But if you look into the numbers and you only include numbers as the cost associated with diagnosis and surgery, we get more or less the same results as the Dutch group, namely a saving of approximately 4,500 euro per patient. The next example is on the use of PET for detection of recurrence and evaluation of therapy in patients with malignant brain tumors. First, a clinical example. This is a lady with a newly diagnosed brain tumor in the left hemisphere. First, to your left, you see the MR scan with a tumor, and then the PET scan, where the tumor is seen to be brightly avid with FET. FET is an amino acid tracer, a marker of malignancy and often used in brain tumors. This scan was performed prior to radiotherapy. 2 months after radiotherapy, the patient returned with a new MR scan, indicating that the tumor was growing. Now, it's well known that some patients after radiotherapy, they will get an apparently growing tumor on MR, the so-called pseudo-progression. But it is, of course, mandatory to know whether this is a truly progression or pseudo-progression. And for that end, PET can help. An FET PET was performed, and we can now see that unlike the initial scan, there is no uptake of FET in the tumor. How you can use PET-CT to improve radiotherapy planning. This is also in the area of lung cancer. This illustrates a model-based cost-effectiveness analysis performed by the Maestro group in the Netherlands. They compared conventional radiotherapy based on a CT scan with PET-guided accelerated therapy. They used PET in the lower group of patients to define the gross tumor volume. It is quite well documented now that if you use PET to define gross tumor volume before radiotherapy, you can decrease the size of the field and at the same time increase the dose to the tumor and increase the chance of tumor control. They compared in the two groups the relapse, the numbers of relapse, the adverse events, the survival in life years, and the quality-adjusted life years and cost. All of this model-based, I should stress that. This illustrates the results of their cost-effectiveness analysis. It's a busy slide, I'm sorry about that. But in the top here, it's the life years and the cost, and in the bottom, it's the quality-adjusted life years and the cost. What you can see in short is that in the base case scenario, which is the dark dot, you get an improvement in terms of life years as well as quality-adjusted life years and only a slightly increase in cost. The incremental cost-effectiveness ratio or cost-utility ratio was 1,700 euros per quality-adjusted life year. PET-CT as a cost saver in oncology, dream or reality? I think it might be a realistic dream. PET is a valuable signpost with a partially deserved, very pricey reputation. But if we use it wisely, it can be a key to cost-effectiveness improvements in the way we treat our cancer patients. And it can perhaps sometimes even be a cost saver. And
you gave a lot of opportunities for questions, which I would like to give to the audience first. Is there anybody ready for a question? Can you explain this a little better for those in the audience who are not too much familiar with these details? And what does it mean for the patient?
And when we talk about stage migration, we mean the fact that when you stage patients better, when you get a better impression of how advanced the disease is, you'll see some changes in survival as well. For example, if you used a poorer staging method, the patients in the lower stage groups, the patients with not advanced disease, will have maybe a poorer survival. But if you stage better, you will find the patients who are actually having advanced disease, discriminating them for the people who really has localized disease. And in that way, you'll actually end up not really improving, but it looks as though you're improving the survival in both stage groups. So it is a kind of reflecting that you get a more accurate image of the stage of the disease if you use a more accurate method for staging.
It is now my pleasure to present Elisabeth de Vries. Professor de Vries is professor of medical oncology and head of Department of Medical Oncology at the University Medical Center of Groningen in the Netherlands. Her research interests are in the area of increasing effectiveness and of anti-cancer drugs, and she uses imaging techniques in her investigations as a medical oncologist. She is the recipient of numerous grants as principal investigator from different national and international organizations, and she chairs the committee for the new RECIST 2.0 version on behalf of the ERTC, and is the co-chair the task force who developed the ESMA magnitude of clinical benefit scale. She has in her team, unusually, several radiopharmacists working on innovative diagnosis and treatment, and I think we will hear about it. We have the pleasure to have a medical oncologist talking to the nuclear medicine field. She will show us our strengths as well as our weaknesses, as we discussed last night. And I'm very pleased to invite Professor de Vries on the table to talk about standard and novel PET-CT scanning in breast cancer.
So I'm going to speak about standard and novel PET-CT scanning in breast cancer. And I'm really a doctor treating patients, and I use PET scanning as a tool. And nowadays, it's really spectacular in my profession what we get as new drugs. The prices are spectacular, but their effects are spectacular as well. So a very important task for us is to try to select patients for the right treatment. And what I will try to show is that there might be a role in this respect for PET scanning. Now, if we look into what we know about FDG PET and what guidelines state, and it doesn't play a role in screening or diagnosis, it can help in staging, a limited role for early breast cancer, but a potential role in metastatic disease. But it's good to realize that the American NCCN guidelines speak about optional, and the European guidelines say FDG PET could be used. And then treatment response, FDG PET is part of the RECIST criteria in case you notice new lesions on FDG PET, but that's it. And there is no proof at the moment that you can use it as an early response measurement. So that's FDG PET. Still, scanning and novel traces might be very interesting. And we know, of course, more and more about the tumor and tumor cells and its microenvironment. And we can make ligands to these targets, and we can add a radionuclide to it, and then we can visualize it. And it's good to realize that at the moment with PET imaging, it's really almost possible to image all key hallmarks against cancer, in cancer. And it's these hallmarks that we use in drug development and in treating patients. So the estrogen receptor is localized at the cell membrane and in the tumor cell, and estrogen, estradiol, binds to it. You can fluor label estradiol, and then you get this kind of images. Here you see normal uptake of the tracer in the liver and excretion in the gut, but in addition you see numerous bone mets. For this tracer, it's really well validated that uptake in tumor lesions matches in that biopsy the expression of the protein of the receptor when you check it with immunohistochemistry. And as far as prediction of tumor response, we now know that if patients don't show uptake in the tumor lesions of this tracer, that they won't benefit from hormonal treatment. You can also use this technique to check how well you're treating the patient. So we checked that for fulvestrant. Now, what is fulvestrant doing? It's going to sit on the receptor and block the receptor, and it's going to degrade the receptor. So we speculated if it would work well, we wouldn't see uptake anymore. We decided beforehand, based on other trials, that we would need an over 70% reduction in order to be meaningful. What you see, this is a patient where we could show in 4 weeks that she had excellent blockade. But this is another patient, no blockade. And this is the real clinical problem. Half of the lesions don't respond and the others do. We are now doing a study in patients where we do visualize the estrogen as well as the androgen receptors. So why are we doing this? Well, because if the androgen receptor is meaningful in breast cancer patients, and it seems to be the case with the most recent data that come out there, then we would have all these prostate cancer drugs that might also be useful for breast cancer patients. What is the fact? These receptors are sitting on the cell membrane of tumor cells, and that's a very dynamic procedure. We label an antibody with a radionuclide, and that you can inject in the patient. An antibody has a very long half-life, that may be up to 3 weeks, so it takes days to travel to its target. So over time, it will find its target, it will bind to the receptor. When it's bound to the receptor will internalize. The antibody will degrade and the radionuclide will remain intracellular. So we started to do this kind of imaging with a SPECT tracer because that was all that was available. And we noticed more tumor lesions with this kind of imaging than we saw with conventional imaging. But nowadays, we do have PET tracers available. When we label the antibody with zirconium, you get this kind of images. Here you see some uptake in the circulation and presence in the liver, but you also see numerous liver mets, bone mets, and even brain mets. And as already indicated in the previous talk, you can quantify how much of the antibody gets in there. What we noticed in the first analysis presented at ASCO last year is that around 30% of the patients did not show uptake of trastuzumab in their tumor. So these may be the patients that won't benefit from this kind of treatment. And here to show you that you can have weird special targets that you can target as well. We did a study with a zirconium-labeled anti-mesothelin antibody. And here the worry during drug development was that the drug probably might not get in pancreatic and ovarian cancer tumors because they are considered to be very difficult to penetrate. And what we could show here is that that's not the case. It does get into these tumors. Now, the most exciting aspect of my profession at the moment is the fact that we have increasing evidence that immunotherapy works across several tumor types. What does it mean? It means that your own healthy cells can attack your tumor. And there was always a break in between, but now there are antibodies that take care of this break, which means that, for example, your T cells can attack your tumor cells. Now, I think for us as oncologists, it would be very nice to know whether these antibodies really get into the tumors of all patients. So we are ready to start a trial, for example, where we have labeled PD-L1 antibody just to check how well it gets in all tumor lesions. So what did I try to show to you? That it's possible to visualize tumor characteristics, that it gives insight in heterogeneity and in drug target effect in the tumor, that it could help to select the right dose of drugs, but we have to prove everything in meaningful, well-powered trials. And that's really not easy. It will be critical that it's safe, that it will add benefit beyond existing care. It would be very nice when it would reduce cost. or burden for the patient. In the end, it should all be of benefit for the patient, and I hope that I gave you some clues that PET imaging might be very meaningful for precision medicine. I would like to thank you for your attention and my people back home and in the different centers we work with. Thank you.
Thank you very much, Professor de Vries. This was excellent presentation of how integrated nuclear medicine has to be with the oncology and other domains in clinic as well. But here you see the very close collaboration between diagnosis and therapy going back and forth. I think this is a very prestigious example of how this collaboration can work between diagnosis and therapy.
A simple question. You have shown a lot of imaging biomarker. For the routine clinical practice, how do you see the role of the industry from that perspective? You know, to have so many new biomarker will be a big challenge for the industry. How do you see that?
So I must say that pharmaceutical companies are at the moment very interested in PET imaging, and they start to become interested in optical imaging as well. So, because that is a way for them in an early development phase to make decisions on, for example, how well the drug gets into the tumor, and probably enrich their patient population and see more meaningful responses while they otherwise might have thrown away a drug. So they were interested. I think pharmaceutical industry and those who develop these nice PET machines all seem to be a little bit reluctant to embark on larger trials. And I think it... So what I hope that I illustrated in my talk is that I think there are numerous opportunities that this may be meaningful. It's just that we have to design reasonable sized trials that give us powerful answers. And if we don't do that, then all these new tracers will die the same way they did over the last years. And there will be more papers on 10 patients with a novel tracer, and it will not be meaningful for patients.
Professor Weber is Chief of Molecular Imaging and Therapy Services at Sloan Memorial Sloan Kettering Cancer Center in New York. He's a German citizen, wie ich auch, and trained in Germany, moved to the United States, came back to Germany, and now is professor in Sloan Kettering, prestigious institution. His current research interest is on the development and clinical evaluation of novel radiopharmaceuticals for diagnosis and therapy in cancer. Another area of research is the use of PET-CT and PET-MR for radiation therapy planning and monitoring tumor response to therapy. So I'm pleased to invite Professor Weber to talk about monitoring tumor response to therapy with PET-CT. Thank you very much.
I would like to start with some more general comments why monitoring tumor response is important in cancer patients. And I think it really becomes apparent if you think about these survival curves that are shown here. I mean, this is a very common way to display how drugs are working in oncology. You plot over time how much patients have survived. And this is shown here for a new ligand that binds to the androgen receptor and that has recently been approved for treatment of prostate cancer. And what you see here on the left side of the slide are the two survival curves of patients that received the active drug and the patient that received no active drug. And I see overall the survival of the patient receiving the active drug was statistically significantly better than the survival of the patient who received no active drug. But what's also apparent from this survival curve is that there are many patients that actually lived longer when they were receiving no active drug than other patients that received the active drug. So what we see here immediately that there is a marked heterogeneity in how patients respond to this, because some patients did actually better although they were receiving no drug than patients that were receiving the drug, although on average, patients receiving the drug did better than patients that did not receive the drug. The right side of the slide shows you also a survival curve, but not the actual survival of these patients, but the time until these patients showed sign that the disease was spreading further, what is the so-called progression-free survival curve. And this disease progression is defined by imaging tests. You see a new lesion on a bone scan or on a CT scan, and this then in general defines tumor progression. And the fact that I would like to highlight here is that these curves split much faster and much more and separate wider than the curves for overall survival. So what this shows is that that imaging helps you to complete trials earlier because these findings on imaging occur earlier than the event of patient death, which is kind of obvious, but I think it's important to remember that this is a reason why we are performing imaging in clinical trials. But what's increasingly realized is that response is also heterogeneous within a patient. And I'm illustrating this here in a patient with breast cancer, and you see the scan before treatment, and these arrows indicate these axillary lymph node metastases that take up FDG and are therefore shown in red here. Now, after treatment, you see that the intensity of uptake here has clearly decreased, and so you would say, well, this treatment is working. But if you look carefully, you see a new hotspot in this area here, and if you look more carefully, you see that this is actually in the cervical spine here, a very dangerous area. It can cause a lot of complications if this lesion grows. So while some lesions were clearly improving in these patients, there were also clearly new lesions in the same patient. And only with imaging you can find out about this and detect this lesion that despite the fact that overall the treatment was working, it was in fact not working because we had this new and potentially very dangerous lesion here in the cervical spine. In imaging, these mixed responses have been known for a while, but as I said, because it's not entirely clear what to do in these patients, they have been ignored a little bit. But it's now increasingly clear that the reason for this probably is this heterogeneity of these metastases that has been described as an intratumoral and intertumoral, but also intermetastatic heterogeneity. And by biopsies, it has been shown that also the epigenetic and genetic features of these different metastases are different, and this probably causes this mixed response on the PET scans. So to summarize these general remarks on the importance of response monitoring with imaging, the key point here perhaps is that malignant tumors are heterogeneous between patients, within patients, and over time. And monitoring tumor response therefore requires spatially and temporally resolved information, or in other words, imaging. What can we do to monitor tumor response with imaging? And we can start here with pharmacokinetic and pharmacodynamic studies that Professor de Vries already touched upon a little bit, and I would like to expand this. And the basic question asked here is, does the drug reach the target, and does it interact with the target? And then the next question is, what happens to the cancer cells once the drug has reached the cells? Does the biology of the cancer cells change in some way? And then finally, does treatment have a beneficial effect short-term and long-term? And answering these questions has enormous potential to decrease the cost of cancer therapy in two ways. The one way is by reducing the cost of drug development, but in the clinic, also stopping ineffective therapies early on. The cost of drug development. This has been in the news now constantly. The price tag for that has been quoted, how much money does it take to bring a new drug into the market, has really reached staggering numbers. Forbes magazine just said it's 5 billion, New England Journal 2.6 billion. It probably shows you that there's lots of different ways how to calculate those costs. But overall, I think there's no question and general agreement that the costs have substantially increased in recent years, and they're probably too high to be sustainable over longer periods of time. What's also been agreed on is that the key driver for these costs is failure of drugs relatively late in the drug development process. And this is from a recent review that developed a model to estimate what really makes drug development expensive. And it shows you here the probability of success in phase 2 and phase 3 studies has the biggest impact on the overall cost of a drug. I would like to give you one example. that illustrates how PET imaging can be used to study the pharmacodynamics of drugs. And this example is about Parp inhibitor treatments. Now, Parp is a DNA repair enzyme which is considered critical for the survival of cancer cells that have a defect in other DNA repair mechanisms, the so-called BRCA or BRCA mutations that occur relatively frequently in breast cancer patients. Now, because of this, Parp inhibitors have been developed for treatment of various cancers, mostly ovarian, breast, and lung cancer. And the first compound entering the clinic was the one shown on the right side here, a drug called Iniparib. This drug has been studied in a large number of trials. This is a list here. You don't have to read the individual trials. But overall, you see it has been studied in more than 2,500 patients. But at the end of this, it failed. And in 2013, the company who made this drug, Sanofi, said the drug is not successful and said basically this is a failure and we stop the further clinical development of this compound, which came at a significant cost for this company that they said is about $285 million. Now, why did the drug fail? I mean, the obvious explanation perhaps would be that maybe Parp is not so important for DNA repair, and there are other DNA repair mechanisms, and maybe we're just hitting the wrong target, and we should look for other targets. But what eventually was found out is that Iniparib is not a Parp inhibitor at clinically relevant dose levels in patients. It works in cell cultures where you can give relatively large amount of the drugs. It works on isolated Parp very well. But in patients, the drug levels were simply not sufficient to effectively inhibit Parp, and that explained the failure of this drug. And this, of course, is very disappointing because enormous resources were wasted in developing this compound, and it also confused the whole field of developing Parp inhibitors because initially it was not clear, maybe it's really that the target is wrong, but before one found out that actually the drug is not acting as it's supposed to be. And actually another Parp inhibitor was recently approved for treatment of metastatic ovarian cancer this year. So, and studies with other Parp inhibitors are ongoing. So how could this be avoided? I mean, as Professor de Vries already shown some examples here, PET imaging can be used to study this blocking of the drug target with the drug. And we have tested this here in an animal model of a brain tumor, and you see that this brain tumor has high levels of Parp. It can be imaged with this Parp imaging agent. And if these animals are treated right before the PET scan with this Parp inhibitor, you see that the signal completely disappears. And this is a different way to display this, again, the tumor before treatment and after treatment. At this early stage, this has nothing to do that the drug has acted on the tumor and has killed the cancer cells. It simply shows that the drug has interacted with the target. And if these kinds of studies would have performed in these initial clinical trials of the Parp inhibitor, the drug would have been stopped in phase 1 or latest phase 2 before accruing such a large number of patients in clinical trials and before realizing that the drug is not working as expected. And this is an imaging agent that targets the androgen receptor in prostate cancer. And you see here metastatic prostate cancer, even if it's considered androgen resistant, still expresses large number of these androgen receptors. Now, the problem has been for many years that while the advantages of PET imaging were relatively obvious for all the reasons that I tried to explain to you, but there was no, in contrast to RECIST, there was no standardized way to actually assess tumor response on the PET scans. But a couple of years ago now, the so-called PERSIST criteria or PET response criteria in solid tumors have been published that very similar to RECIST now provide a standardized framework how to assess tumor response on FAG PET scans. And the result is that this can now be used in clinical trials in a systematic way, and the results of different groups using the same criteria can be much better compared than before. One example is to change treatment in patients that receive neoadjuvant therapy. And the reason for this is illustrated here in patients with cancer in the distal esophagus. And it has been known for quite a while that if these patients receive chemotherapy before surgery, if you look at large number of patients, their outcome is somewhat better. But it's really very small. Because also has been known, if these patients are operated on, and if the therapy has really worked, meaning that there are only very few or no tumor cells left after chemotherapy, then those responders do much better than patients that are classified as non-responders. So the question is, can we identify those non-responders early on? Showing that PET responders have a much higher probability of achieving a histopathologic response, in this study 34% as compared to 4%, and have a better survival as patients that are classified as non-responders. So based on this, one can then perform so-called response-adapted therapies, such as this Immunotherapy trial that has been published a couple of years ago, where non-responders on the PET scan, the treatment is stopped and patients are operated on immediately, and therapy is only continued if the PET scan shows a response. And what was very encouraging in this trial is that the histopathologic response rate in this group of patients was 58%, which is really unheard of for a chemotherapy-only regime in unselected patients. So it really seems that the PET scans helps to identify those patients that are much more likely to benefit from this therapy. So eventually, the role of FDG PET in oncology could be that you start with a genetically defined sensitivity to a specific drug, but that you also realize there are many confounding factors that may be present before treatment or that may develop after treatment, and that result then in a secondary resistance or primary resistance. So the outcome in the individual patient is not clear despite all this characterization of the tumors prior to treatment. And therefore, a rapid readout, if the drug is working and how long it is working, I think will remain important. And therefore, then changes in treatment can be performed in patients that are responding, and the treatment can be continued in patients that are non-responding.
Since 2005, he is founding member and co-chair of the National Oncologic Pet Registry, called NOPR, the efforts to which have helped greatly improve the expanded coverage of PET by the medical program. And I'm pleased to invite Professor Siegel to talk about impact of PET in cancer. Thank you.
Thank you, Conradi. Thank you for that kind introduction, and thanks to the organizers for having me make the long trip to be here. I'm really delighted to do it. You gave my age away, I guess, but that's okay. So we've heard a lot of heavy science. I'm going to talk a little bit more about politics and interacting with government agencies and how we tried to show using a different approach combined with the large accumulated mass of data on PET, how PET could really be helpful in cancer management. Here are my disclosures. And I think everybody in the room knows this. I mean, PET was nominally invented in its current form at my university in the mid-1970s. And it took a very long time for PET to come from those early devices that Mike Tirpagosian and Mike Phelps built to flow into clinical practice. And then, of course, we had to define reimbursable clinical indications. This is mostly determined by technology assessment panels of third-party payers. And there have been very interesting analyses of how different technology assessment panels look at the same data and come to very much different conclusions. And in the United States, the process is dominated basically by our Centers for Medicare and Medicaid Services, or CMS, which is the government agency that administers the Medicare program and helps with the Medicaid program as well. But in the 90s, CMS appropriately adopted a new evidence-based approach for making its coverage determinations, requiring that there be good peer-reviewed scientific evidence to document that the new technology led to improved health outcomes for Medicare beneficiaries, or as a minimum, some appropriate change in management. We'll talk more about that in a bit. The PET community in the United States went to Medicare and said, you know, there's a lot of evidence, and we think that you should consider PET for broad coverage. But Medicare decided that that's not what they were going to do, and rather they said, we're going to look at PET on a cancer-by-cancer and indication-by-indication specific basis. Well, that was great, but the problem with that is that the specific evidence, when you drill down to that level, has typically not been very robust. So we found ourselves in a classic catch-22 situation. We couldn't get coverage because we didn't have the evidence, and we couldn't get the evidence because we didn't have coverage, because there was no other way to pay for the PET scans. Now, there have been a number of randomized controlled trials. This is a summary that's about a year old, but there hasn't been any new one published since. And we find that we get results that, for the most part, are in the direction we expected with the earlier non-RCT type studies. So in the United States, Medicare first decided to cover PET for the solitary lung nodule and for initial staging of non-small cell lung cancer in 1998. The next year, we got some additional coverage for 3 more cancers. 2 years later, we got what I would have called the big 6 cancers for diagnosis, staging, and restaging. And then between 2002 and 2004, my late colleague Ed Coleman and I helped organize about a total of 15 petitions that went to Medicare to ask for coverage for additional cancers. And basically, it's an option for providing coverage for promising medical services that don't meet their evidentiary standards for being reasonable and necessary, but look good enough that maybe if we covered them while we're still gathering some data, we might be able to then make a better policy decision. Now, the objective of the Pet Registry was relatively simple. It was to look at the effect of PET on referring physicians' plans of intended patient management before and after PET. And we wanted to do this across the full spectrum of cancers and cancer indications that were not currently then covered by the Medicare program. And we found that PET led referring physicians to switch to another therapy in about 25%, to adjust the dose or duration of therapy in about 1/6 of patients, and then to switch to observation or supportive care in about 6% of patients. And to no one's surprise, when the PET scan indicated that the patient's disease was getting worse, the likelihood of changing therapy was much higher. And in just a little over 2 years ago, we got a next national coverage determination. PET was essentially extended to so-called subsequent treatment strategy for all cancers with a 3-scan limit. More about that in a moment. And the data collection for FDG PET was ended, and now we're out from this activity. Now, the strengths of our data are that, first of all, this is real-world data. This is not a highly controlled clinical trial. We didn't tell people how to do their PET scans, how to report their PET scans. We're looking at what's happening in everyday practice. We collected a lot of data, and therefore we're able to do things with it in a very timely fashion. Limitations are data quality. We know that these essentially non-engaged referring physicians didn't really have any absolute reason to provide us with high-quality data. There's always the potential that physicians who want to use PET could have been biased in the way they responded to try to make it look like PET was more valuable than it was. Like any single-arm observational study, there's no control group. And this is a fundamental problem. Our data do not address whether PET should be used instead of other imaging or as a complement to other imaging. We have no evidence to tell us what to do with sequencing, and that remains a very, very important question. And we really can't tell the answer is how much better is PET than the next best method. So in closing, let me just say that the NOPR has successfully used one pathway to help achieve coverage for PET in cancer in the United States. This pathway was slow, quite burdensome, and what we're going to be doing next is even more burdensome. It's clear that a couple of things need to happen. First of all, clinical trials of new molecular imaging agents have to focus from the outset not only on the simple sensitivity, specificity, accuracy measures that we've also always used, but we need to try to, at that early stage, get evidence of improved patient outcomes. It's unlikely that we'll get everything we need to meet FDA's barrier, and so to meet the insurance coverers barrier, we need to hope that they will continue coverage with evidence development as a standard approach for developing further evidence as we evaluate these new tracers and methods in molecular imaging. Thank you for your attention.
I think I would like to pass the microphone to Professor de Vries. As the oncologist, we were talking about the many different traces which need evidence development. And how do you foresee the collaboration with the nuclear medicine community to get the evidence we need for to put new traces really on the market, meaning available for patients on a larger scale?
I'm not at all worried about the collaboration with the nuclear medicine physicians. I mean, we have so many friends in Europe, all of us, and we would love to work together. I think really a main issue is money. Not the intention to do it.
Well, I think it's even nicer if we could try to pull prospective trials and we have from our trials where we have all done the imaging in a harmonized way, in a similar way, etc. I mean, that is a way to get very nice data. I like the US approach, but you need, again, money in order to be able to do it.
Yeah.
So,
how can we balance this? Therapy monitoring. We all want that therapy is monitored. We also have to show evidence in this area. Professor Weber, how do you look at the development in the evidence generation under our conditions? So,
I mean, the aspect of money has been raised, and I think it's really the key issue, because especially for treatment monitoring, many interesting trial designs would lead to less use of chemotherapeutic agents, and this is not what traditional pharmaceutical companies would fund. And so I think that really has been an issue to move the ideas of these response-adapted therapies forward. And I think what one also has to realize is that the patient numbers are significantly larger as for a trial that looks at sensitivity or specificity of an imaging test, because as Barry pointed out, the response assessment is only one part of it, and then you have to have a drug that is active in the non-responders. If you want to do this kind of paradigm, then of course these numbers become big, very large, and the randomized trials become large.
but you were talking about the amyloid plaque tracers, and these proprietary drugs are, some of them, in the hands of big pharma companies. So this might be the first important, don't you think?
I mean, they're
so?
already, go ahead.
I think that as soon as nuclear medicine could show better that they all will do the test the same way, because what pharma companies like is, whether it's sodium or potassium or whatever, they like the sample of the patients to be determined on one spot. And they can do that for whole genome sequencing, for RNA analysis, etc., but they can't do that for PET scanning. So
Sure.
that makes them more nervous as soon as a randomized trial has to be done. So the better nuclear medicine physicians can make clear that they really can act all in the same way, the more confident they will be, and then hopefully they will embark, because I think there should be a good reason.
What are the Scandinavian government is saying about the future development of new radiopharmaceuticals? Are they ready to give coverage with evidence development easily or not?
Well, I think maybe reimbursement will be the minor part in that. It will be the improvement of new traces and to use new traces, develop new traces and use those in trials with humans. That is a huge obstacle in Denmark and in, I guess, the whole of the European Union. So the development of the traces might be the first and largest obstacle at the moment. But I would also think that we should not completely forget FGG in this. It's a really great tracer for a lot of things, especially for therapy evaluation and also for prediction. We're currently looking into ways in order to predict where will a patient relapse. And if we can predict where the patient will relapse, whether it's in the primary tumor or in the distant metastasis, we can also act on this. We can give a sort of chemotherapy, and then we can make stereotactic body radiation on this specific site. So there's also the possibility that you can tailor trials around an already known and approved technology.
How can we leverage in those registries? We all have to do registry. There's no question we're going to have to do it, because that's probably the way to get reimbursed clinically and collect data at the same time. Is there any effort in trying to combine those registry with some guidelines so that we do the same thing, and to avoid small country like ours to try to do it by themselves and fail?
Good question. So there is the Agency of Healthcare Research and Quality in the United States has put together this huge manual on healthcare registries. They've updated it a couple of times. So there's a lot of information in there about registry design and quality control that is available to tap into. I agree, for Switzerland to do it in a small population is tough. So it sounds like these registries need to be rolled out in a wider fashion in Europe to match the kind of population that we're working with in the United States. I would point out that there was something unique about NOPR that's not occurring with this new amyloid registry that's expected to open sometime in, it's really not a registry, this new amyloid trial that's expected to open sometime in January. Under the previous conditions, we were allowed to continue providing access to the service until the point where we got a coverage decision, even though not every patient for whom we gathered data, that data was not used in the papers that we published, because the papers were published up to a point in time and we kept doing studies. With the amyloid registry, we had to project a sample size, and when we finish that data collection, coverage is going to stop. And it's going to stop for probably close to 3 years. I've always wanted to do the simple randomized trial where patients would come into the hospital and they'd be randomized to the imaging group and the no imaging group. And we just look at simple outcome measures like length of hospital stay and mortality. But I don't think there's any IRB in the world that would approve that study currently.
I think you just should, as a non-nuclear medicine specialist, my advice to you is to forget about survival as an outcome. We still don't have any agreement that mammography improves survival. Okay? We're still arguing about that 30 years after. Forget it. It's just so many other things are going along the way. And I think that the approach that Elisabeth and I were having a little dialogue about earlier is the way to go. I need to see much more investment in research from the companies who are producing these radiopharmaceuticals. They can say, okay, the expense is going to be very high later on. Well, let's see some of the money being spent now to justify that expense, frankly. I think that the nuclear medicine group, and I look to the incoming president, could do with better window dressing. You don't sell yourself very well.
I think we have many opportunities. We do have, as a joint community, interdisciplinary community, a lot of challenges on the clinical side, on the development side, on the regulatory side, and not the least also from the industrial side. I think it's time to work together. The only way I would say that we will be able to overcome those hurdles.
Thank you. I will not be very long. I'm Guy Turquet de Beauregard. I'm the AIPES president. And I have two messages to give you. The first one is very, very obvious. I really would like to thank very, very much the four speakers for coming from very, very far away from US and from different countries in Europe. So I think I'm very proud of this symposium, and again, I would like to applaud you and thank you very much for coming.